Aloha and a very warm welcome to all of you, our participants. Thank you so much for joining us this morning. This is the fourth of six webinars that will be introducing and sharing highlights of the 2022 Statistical Report for the Hawaii State Plan for a data-driven system of care on substance use. This webinar will be focused on Chapter 9, which is looking at the intersection between substance use and Native Hawaiian communities, and Chapter 10, looking at the intersection between substance use and rural communities. My name is Devereaux Talangi, and I will be your facilitator for this webinar. Before we get started with our presentation, I would like to give a few housekeeping reminders. First, this is a Zoom webinar event, which means that you, our audience, are able to see us, the panelists and the presenters, but we cannot see you. There are two ways to interact with us and between yourselves. The first is through the chat window, which you should be able to see on the Zoom status bar, and the second is through the questions and answers window, which you should also be able to access through the Zoom status bar. We encourage you to post questions and comments, as well as to introduce yourselves, as it will help to make the webinar more interactive and add to the discussion. Our panel and team will try to answer your questions as they arise. However, we also do have time allocated for discussion, so our panel may try to answer questions at that time. There will be 4 poll questions that will be posted throughout the presentation. There is also a short post-webinar survey at the end that will pop up when you leave the Zoom room. Your feedback is very important for improving the webinar series, so please consider spending a minute or two after the webinar ends to fill out the survey. Finally, we will be providing the slide deck with all of the supplementary material, contact information, and links to all our participants after the webinar. A recording of this presentation will also be available next week. The recording for Webinar 1, Webinar 2, and Webinar 3 are now available, and the link will be provided as well after the webinar. Okay, now I will introduce our panel. Our first panelist is John Valera from the Hawaii Department of Health, Alcohol and Drug Abuse Division. John is the acting administrator of the Alcohol and Drug Abuse Division, and in that role is the sponsor for the State Plan project. He has served at the ADAD in various capacities since 2016 and is a certified planner with the American Institute of Certified Planners. He has a master's in urban planning from the University of Hawaii and a Bachelor of Science in Planning and Public Administration from the University of Southern California. Our second panelist is Dr. Jared Euro, also from the Hawaii Department of Health, Alcohol and Drug Abuse Division. Jared has a Doctor of Psychology degree from the United States International University. He completed his master's in education at Columbia University and received his master's in psychology from the California School of Professional Psychology, San Diego. He is a licensed psychologist, and since 2002, he has worked for the Hawaii Alcohol and Drug Abuse Division, where he serves as Chief Clinical Officer, Clinical Psychologist Supervisor, and currently as Acting Public Health Program Manager. Our third panelist is Lilinoe Kaua Hikaua from Papa'olaukahi. Lilinoe is the population health specialist focusing on behavioral health, mental health, and addictions. She has a master's in social work from the University of Hawaii at Manoa, and she also received her BA in the Administration of Justice with a minor in Hawaiian Studies from the University of Hawaii at Hilo. Her research includes data disaggregation and indigenous approaches to behavioral, mental health, reentry services, incarceration, and substance misuse. Lilinoe currently serves on the Hawaii Advisory Council on Drug Abuse and Controlled Substances, the boards of Kolu, Meanui, Going Home Hawaii, and Nohi Mananui. Lilinoe is the subject matter expert and lead author of the System of Care chapter of the State Plan Project, focused on substance use and Native Hawaiian communities, which is titled Conceptualizing a New System of Care in Hawaii for Native Hawaiians and Substance Use. Our fourth panelist is Dr. Kelly Withy from the University of Hawaii, John A. Burns School of Medicine. Kelly is a professor of family medicine and community health and the director of the Hawaii Pacific Basin Area Health Education Center. Her research focuses on health, workforce assessment, and health careers development. She is the primary physician workforce researcher in Hawaii and has developed the only statewide database of supply and demand for physician services. She has designed programs for all years of schooling that are being employed, with more than 4,000 students a year. Kelly is the subject matter expert and lead author of the System of Care chapter of the State Plan Project, focused on substance use and rural communities in the state of Hawaii, which is titled Rural Hawaii Substance Use and Interventions. Welcome to our panelists. We are also very pleased to have another one of our team members joining us today to help present our chapter highlights. Sarah Asuda is a Policy Research Associate at the Pacific Health Analytics Collaborative at the University of Hawaii at Manoa. Sarah holds a Bachelor of Arts degree in Public Health from the University of Hawaii at Manoa and has grown to be a key member of the State Plan team, which she joined shortly after the project began. Along with Jacqueline, who helped present at the last webinar, Sarah is one of our primary programmers and authors behind the 2022 Statistical Report, writing the computer code to generate tables, graphs, and compiling the data from various data sources using R and LaTeX. In addition, Sarah has assisted with the development of the Hawaii Behavioral Health Dashboard, including the interactive data dashboards created with Power BI. Well, please welcome Sarah. We are very happy to introduce the talent behind the work on this project and look forward to having more of our team members in the 2 upcoming webinars. Again, my name is Dev Talangi. You can call me Dev, and I am your facilitator for today. I am an assistant researcher at the University of Hawaii at Manoa, co-principal investigator of the Data Infrastructure Core of the State Plan Project, and the lead author of the 2022 Statistical. This presentation is separated into 2 main parts. First, our panelists will walk you through highlights from Chapter 9 of the report, looking at the intersection between substance use in Native Hawaiian communities, followed by a short discussion. Then our presenters will walk through the highlights for Chapter 10 of the report, looking at the intersection between substance use and rural communities. Again, this will be followed by a short discussion. Please post any questions you have in the chat for our panelists to answer, and we do also encourage you to post your own answers and comments on the discussion issues. Since we only have 1 hour for each of our webinars, our goal for this webinar series is to introduce and highlight some of the findings from the 2022 report. If you are interested in viewing the draft version of the full report, a link and password is now being provided to you in the chat window. We noted that there were some issues with copying the links from the chat window in previous webinars, and so we sent an email with these links to all of our participants right before the webinar started. So please check your email if you are having difficulties. Please note that since this statistical report draft is still in the consultation process, it is a view-only version and is not available for download. Alternatively, you can also view the highlights provided in this webinar either in an interactive or infographic format at the Hawaii Behavioral Health Dashboard. That link is also being provided to you right now in the chat window. It is also included in the email. Before we move on to the chapter highlights, I wanted to give a few reminders about the data sources used in this report. I had addressed these in previous webinars, but I think for anyone joining for the first time, some context will be helpful. There are 18 data sources that were used for this iteration of the statistical report. They fall into these 3 general categories. However, some of them do have aspects that belong in multiple categories. Each type has its own pros and cons, but the main thing we were looking for is that the data can be validated either from the source or by us through our own methodology. Some of the key data sets that are used throughout the report include the National Center for Drug Use and Health, the age cup hospitalization data, and the Web Infrastructure for Treatment Services, also known as WITS. These 18 data sources were determined to be the best available that we had access to up until the current draft was finalized in February of this year. Many of these data sources are available publicly, but some are only available due to the partners who gave us access to their data. We are aware that there are the data sources which may provide more comprehensive or newer data, but unfortunately, due to various reasons, we do not necessarily have access to that data at this time. The reproducible analytics framework that was built to produce the report will allow us to make updates to the report with fairly minimal effort as that data becomes available. If you would like to know more about the methodology that was employed to produce this report, please do refer to the report itself. Chapter 1 of the report covers what I went over in greater detail. If you would like to know more about some of the limitations of each data set, The appendix of the report outlines this information for every dataset along with links to further references. I will attempt to outline some of these as we go through the sources for each chapter. Now we will move on to the highlights for Chapter 9, which is focused on substance use and Native Hawaiian communities. And we will begin with our first poll question, which is, how familiar are you with substance use issues affecting Native Hawaiian communities in the state? I will give you a few moments to provide your answer. Okay, thank you. We also have our second short poll question, which is, are you directly involved with providing substance use services for Native Hawaiian communities in the state? Again, I'll give you a few moments to provide your answer. Okay, thank you. So before I hand it over to John to take us through the highlights of this chapter, I will give a brief overview of this chapter. So this chapter is split into 3 subsections. The first subsection is looking at substance use, abuse, and dependence, and the Native Hawaiian communities in Hawaii. The primary data sets used for this section are the National Survey on Drug Use and Health, the NSDUH, the Behavioral Risk Factors Surveillance System, and the Youth Risk Behavior Survey. The NSDUH is a large and comprehensive national in-person survey conducted by SAMHSA. It is publicly available and it has been conducted over several years, which means its methods have been refined quite a bit. The downsides are that surveys of this size and complexity do have trouble with getting a large enough sample size, especially for small states like Hawaii. One of the ways we got around that was to take pool averages of either 2, 4, or 6 years rather than individual years. While individual years data availability is usually okay for more general indicators, we do run into problems of cell suppression when looking at specific indicators, and we decided that having a more consistent approach for comparisons was a higher priority. The BRFIS is the nation's premier system of health-related telephone surveys that collects state data on health-related risk behaviors, chronic health conditions, and use of preventative services. The survey is coordinated by the CDC and in Hawaii is administered by the Department of Health. Data are collected monthly and survey questions include alcohol and marijuana usage, demographics of age, gender, and ethnicity, race. Limitations with the data from the BRFIS are related to limitations from surveys in general, including issues with self-reporting such as under or over-reporting, and sample selection bias, which is related to the fact that not everybody may have access to a phone. Regardless, the BRFIS is a well-established and long-running publicly available data source, and there is a comprehensive methodology intended to mitigate many of these limitations. The YRBS is another publicly available national health survey conducted by the CDC and in Hawaii is administered by the Department of Education in partnership with the Department of Health. Data are collected regarding health risk behaviors amongst 9th through 12th grade students, including alcohol or other drug use and tobacco use. Limitations are again related to issues that surveys in general have, as I mentioned. And again, there is a comprehensive methodology behind this survey, and the YRBS is considered and used widely also. 2 points that we noted that are relevant to small states like Hawaii is that counties that have a response rate less than 60% are not analyzed. Another is that other than core questions that are standardized by the CDC, comparable national data are not available for some of the indicators in the Hawaii YRBS. The second subsection for Chapter 9 looks at the emergency visits and hospitalizations. The primary data sets for this subsection are from the Healthcare Costs and Utilization Project. We examined individual visits to the hospitals that were recorded as having both substance use and mental health as primary or second, substance use as primary or secondary diagnosis. We had 2 separate datasets for this, although they belong to the same larger age group family. The datasets contain very comprehensive record level data from all the hospitals in the state, with the exception of 2 which are military. The downside is that this data only goes up until 2014 and does not track individuals or identify hospitals. The last subsection in Chapter 9 looks at treatment services. The two data sets used are, again, the NSDA, which has been discussed already, and data compiled by ADAD from the WITS dataset. The WITS provides information on clients receiving substance abuse treatment services from ADAD. This data is not publicly available and was extracted and compiled by ADAD and our team. A key advantage of the WITS is that it has data about the population in question. However, the WITS is limited to a subset of that population who gets substance use treatment through public funding and does not capture those seeking substance use treatment through private means. We also have access to the entire dataset and can track individuals. However, there are challenges with the transformation of the data. One specific challenge that I will note with finding and collecting data for this chapter is that each of these data sources seems to have different categorizations of races and ethnicities. Some have many different race categories, some do not, and the definitions of what may be included do differ. There are also issues regarding language barriers or access to phones or to be selected when surveys are conducted. This lack of standardization is not unique to this subpopulation and is in fact present throughout the entire report for many indicators and other subpopulations, but does pose a challenge for this particular case. This next slide outlines some of which I just went over, but again, if you want more detailed information about each dataset, please refer to the appendix of the report itself. Okay, so now I will pass it over to John to start us off with our chapter highlights.
Thank you, Dev, for the very useful summary of the availability and the limitations of each data set. Good morning, everyone. Happy Aloha Friday to you. We are here to share a few highlights. Since we only have an hour together, just a few highlights, just a taste of what will be in the full reports, which we will make available to you for review and comment. This slide is from the NSDA, National Survey on Drug Use and Health, and it highlights, it basically says the annual average from 2015 to 2018, 4-year average of Native Hawaiians who used alcohol in the past year in the state of Hawaii was 6th highest compared to other ethnicities and was lower than the state average. This Native Hawaiian figure for just under past year alcohol use under 60% is also slightly lower than the US average annual percentage for past year alcohol use, which is around 65%. So next slide, please. Okay, this slide talks about the 30-day current drinking and 30-day binge drinking in the state of Hawaii by race. In 2017, it suggests that this is from the BRFIS, which is that telephone survey that Dev mentioned. It suggests in 2017, Native Hawaiians had the 3rd largest 30-day drinking and binge drinking percentages among all ethnic groups in the state of Hawaii. Okay. Next slide. This is from the Youth Risk Behavior Survey, or the YRBIS. It suggests that from 2011 to 2017, you look at that top pink line, the Native Hawaiian population had the highest percentage of public school students who have ever used marijuana compared to other races and ethnicities. Just be aware these graphs are simply highlights, so it's not to suggest that Native Hawaiians only use that marijuana is the only issue here. So, okay, next slide, please. Whereas this slide talks about the Native Hawaiian population in terms of have they ever used prescription drugs without a doctor's prescription among public high school students. So in 2017, Native Hawaiian population had the second highest percentage of public high school students who have ever used prescription drugs without a doctor's prescription. Again, look at that pink line towards the top. All right, next slide. And I believe I'm going to defer to Dr. Euro for the next segment. And I'll be standing by for any questions.
Well, aloha kakahiaka, everyone. Good morning. So this section, or this slide, I should say, is going to be looking at emergency department visits for 100,000 residents with a primary diagnosis related to any substance in the state of Hawaii by race. And these are for the years from 2005 to 2014. This is based on the H-Cup, to which Deb referred to earlier, as well as the State Emergency Department database. I think the best way to visualize this, it's almost like we think of pie charts. Well, this is sort of like what I call almost like a square pie or pie chart, but we're taking a look at it over time. And so if we went ahead and looked at Native Hawaiian, looked for kind of that slice of this square longitudinal pie from 2005 to 2013, we get a sense really of the percentage related to visits per 100,000. And so you notice where the kind of the pink bar sits, we notice sort of the trend upward. And this is in comparison with some of the other groups, other ethnic groups that are featured here. So again, look at the trend line when we look at Native Hawaiian, which is featured in the pink. Next slide, please. So this slide, also from HCUP and from the SED, emergency department visits for 100,000 residents with a primary diagnosis related to amphetamines. And we certainly know that meth use has been one of the major concerns and areas of study or focus in the state. And here it lists again by race for the years from 2005 to 2014. So again, looking at this as sort of like our, I guess I could say our longitudinal slice of pie, looking at where Native Hawaiians fit and that kind of section of pie from the years from 2005 to 2013 relative to other ethnicities. As you can see for Native Hawaiians, it's really kind of one of the larger sections of pie that we see here. And again, look at the visits of per 100,000, ranging anywhere from 0 all the way up to 400. So a significant chunk of those 400 as we move past 2013. Next slide, please. So this is actually what's called a spider graph, if I understand correctly, and this is something newer that I have learned about more recently. And looking at aided funded treatment admissions for Native Hawaiians in the state of Hawaii by substance for more recent years. This is actually from 2018 to 2020, and this is for a 3-year total. So again, looking in the center, which is really 0, and then projecting outwards along the spider graph, all the way up to a high of 3,500, you can see where substances such as methamphetamine sit. So you're looking at between 28 to 3,500, which is actually considerably quite high. And then if you go ahead and look at marijuana or hashish or THC use, and then you look at alcohol, for many of you who work in this field, probably are not too surprised by what you're seeing really indicated here. And next slide, please. And so this is also aided funded treatment admissions for Native Hawaiians in the state of Hawaii by referral source, again, for a 3-year total from 2018 to 2020. So again, looking at it projected outwardly from 0 all the way up to 3,500. And we look at the referrals that can take place among the different. So you have, whether it be an alcohol or drug abuse provider, could be an individual or self-referred, criminal justice, peer friend, parent family, child welfare service, other community referral, school, meaning educational setting, or other healthcare provider. And so you look at, for individual self, appear to be the majority between 2,800 to 3,500. But you notice also there are quite a number of referrals from the criminal justice system. And that takes us to the next slide. And I will be turning this back over to Dev.
Thank you, Jared. So we are now at the discussion portion of this first half. And before I hand it over, go to the discussion questions, I wanted to answer the question that was posted in the questions and answer. We'll have access to the slide presentations. Yes, sorry, I accidentally pressed answer live. But yes, we will be sending out the slides to everybody at the end of the webinar. And I will move on to our first question, which is, as subject matter experts, what are some of the key highlights on substance use among the Native Hawaiian communities that you would like to share with the audience? And so this question, I'm going to pass it over first to our subject matter expert and the chapter lead for System of Care, Lilinoe from Papa'ololokahi. And then, as she answers, if the other panelists would like to weigh in, they can do so. Thank you, Lilinoe.
Mahalo. Mahalo for sharing the data with us. And, data is a really important part of what all of us do, because data can really tell us a story, So it shows us also why it's important to collect that disaggregated data, right? So we can have an accurate picture of what story that data is really trying to tell us. And sometimes we also run into issues with ethnically disaggregated data because, when we're looking at multiple different places of collection, as was shown in the beginning of this this presentation, oftentimes that data can be collected differently and disaggregated differently. So sometimes that can be an issue in really collecting an accurate picture. It's also really important to understand the root causes of the disproportionate number of Native Hawaiians represented throughout this use data. So some of the key highlights that we cover, that we also cover in our chapter, I think, are the cultural, historical, and intergenerational traumas stemming from the impact of colonization and how these issues have been linked to higher rates in health disparities for Native Hawaiians, as well as the overrepresentation of Native Hawaiians across social services, which includes mental health and addiction services, as well as incarceration and reentry, and specifically for drug-related offenses. All of these which have really significant impacts on individual, ohana, keiki, and community health. So today we have many of our Native ohana that have become disconnected from their cultural heritage throughout generations. And this is, our cultural heritage really provides us with protective factors, right? So we also need to remember that our culture also passes down strengths intergenerationally, right? So this is really these intergenerational traumas is something that we also really see manifesting as substance use among Native Hawaiians. So since we've seen this overrepresentation of Native Hawaiians in treatment services over the past 2 decades or more, this is also a really good indication that there is this need to re-envision services for the Native population, really utilizing cultural reconnections and methodologies that speak to Native perspectives particularly. So some of the key aspects that we like to focus on, and that you can actually read about in our chapter as well, is really understanding Hawaiian ma'i, right? Hawaiian sickness from a cultural perspective, taking a deeper look into Hawaiian assessment and how that was used to assess Hawaiian illness versus illness that came from more recent causes, like introduced causes, as well as creating culturally safe spaces for Native Hawaiians accessing services, but also Native Hawaiians that are in the addictions workforce, right? Because these are our Native Hawaiians that are providing a lot of these cultural pathways. It's important to look at that disconnection between Western evidence-based practice and Indigenous ways of knowing, because our Indigenous ways of knowing really predate Western evidence. So it's important to kind of look at where that disconnect is and how can we uplift our Indigenous ways of knowing, because we know that this is more effective for our people. And then we look at examples of culturally grounded interventions and programs here in Hawaii, as well as from other indigenous populations around the world. When we try to look for ways to, again, uplift them and provide funding, because many of our culturally grounded programs don't necessarily qualify for the same funding streams that support many other Western evidence-based practice. So there's, again, this real need to bridge this gap, right? Whether it be in uplifting indigenous knowledge base or developing cultural intervention, or whatever may be needed in that area. Some of the other things that's important to kind of look at that we also included in our chapter would be examining peer services models, recovery and resiliency oriented systems of care, and recovery ready communities, and the alignment of those models with indigenous understandings and indigenous ways of healing. But I think what is also really important to note about substance use among Native Hawaiians is that it's often a symptom of a much larger or deeper trauma. So we really need to put in that extra effort to follow these issues upstream, to really get to the root of these traumas rather than solely target just the surface manifesting symptoms of use, and really focus on a more approach that's more collective in healing our communities and our ohana, right, in order to help heal the individual. And that's something that's often reversed with more clinical or Western treatment methods.
Thank you so much, Linoy. Does anyone else on our panel want to weigh in? I see Dr. Euro.
Yes, yeah, aloha again, everyone. One of the things I wanted to comment is when I have looked at data in terms of the number of admissions regarding different ethnic groups, I would say a number of years ago, when I looked at the number of Native Hawaiian admissions, roughly between 40 to 50% of those who come into our treatment programs for services are Native Hawaiian. Now, this is going to have some variability island by island. Certainly when you might compare Oahu with Molokai, with Hawaii Island or Kauai. But on the average, we're looking at 40 to 50%. So when you look at ADAD's continuum of care and how its services are set up, certainly knowing this has an impact in terms of how we are going to go ahead and recognize the needs of this particular group. The other thing I wanted to point out to everyone is that Hawaii ADAD follows, and a number of you may know, the Alaska, it's the Cook Inlet Tribal Council model. This has been a part of its request for proposal process for a number of years. This was done back in 2007. It's actually both SAMHSA sponsored, as well as sponsored by the International Initiative for Mental Health Leadership. And the reason I bring this up is it is a model which is based on what is considered both practice-based or indigenous evidence, as well as what could be called Western-based evidence. It's really a very unique model. One of the things you may know from those of you who have worked with the Liliuokalani Trust, formerly known as the Queen Liliuokalani Children's Center, is the model is what's called the weave. And the weave is the idea that you really have this weave of what can be considered to be indigenous or Hawaiian practice and Western practice. Or as Lily Noe referred to earlier, you have ma'i, and you have what could be called indigenous or Hawaiian ma'i, and you also have Western ma'i. So illnesses can come from many sources and can be looked at in different ways. And so what I'd like for everyone to realize is that this guides us such that when you look at the array of services and how ADAD provides in our service array for our substance abuse treatment programs to offer services, culture is one of those areas that is taken into account very strongly as far as the full array of services in terms of how practitioners can go ahead and work with our consumers. Mahalo.
John, did you want to share briefly on this question? You had your camera on.
Oh yes, I'm just listening, and I totally concur with Lily Noy as well as Dr. Euro. We're trying to do our best to promote cultural practices or indigenous methods of healing, especially and addressing the upstream roots of that trauma that led to the substance use and a number of other possibly co-occurring sorts of issues with other chronic diseases. And thank you, Dev, for replying to Greg. I was wondering about that as well, because usually we tease out the adolescents from the adults and report the population separately. But with respect to, we are seeing an overrepresentation, unfortunately, of Native Hawaiians among the substance use or drug use. And we just finished a school year alcohol, tobacco, and other drug study, and I believe Dr. Jane Inoue is in the audience. This is pretty much her work, but of sampling a lot of public high school students and Native Hawaiians, including those that are who identify themselves as having two or more ethnicities with Native Hawaiian are overrepresented. And so we see the need even in the ADAG clients that we serve indirectly through our substance use providers, many of whom are in the audience. Native Hawaiians are also overrepresented, and so we're looking for to try to work with our providers to encourage those to encourage those practices, and I think this is the good opportunity to solicit your feedback on how we can continue to do that. And thank you, Laura, for chiming in the chat. And we find that especially the intergenerational trauma is also echoed among the First Nations. And what they went through. Dev, back to you.
Thank you so much, John, and the rest of our panelists. I think we do have a couple other questions here for the discussion, but since we are limited on time, I think we should move over to our next section, which is looking at the highlights from Chapter 10, which is on substance use and rural communities. And to start off this this section, we have our poll question, which is: how familiar are you with substance use issues affecting rural communities in the state? Again, a few moments for you to provide your answer. Okay, thank you. And now for our fourth poll question: are you directly involved with providing substance use services to rural communities? And it's a multiple choice yes or no question. I'll give you a few moments. Thank you so much. Okay, before I pass it over to Sarah to start us on our highlights for Chapter 10, I'll go over the subsections for Chapter 10 briefly. So there are two subsections in this chapter. The first is on substance use, abuse, and dependence, and there are three data sets used for this subsection. First is the NSTA, the National Survey on Drug Use and Health. the Behavior Risk Factor Surveillance System, or BRIFIS, and the Youth Risk Behavior Survey, or YRBS. I already went over these in the previous section, and so the next section is treatment. And the main data set used for this section, again, is the National Survey on Drug Use and Health, or NUSDA. Again, I've already went over this in the previous section, the limitations, some of the limitations that we came across. One specific challenge for this chapter that I'll mention again is that sometimes these smaller counties have a difficult time getting enough of a sample size, and many times the numbers are suppressed, especially in some of the survey data that we're looking at. This isn't unique to Hawaii, but it does mean that we, in some cases, have to go to a wider time period, as I mentioned before, and use aggregated data rather than looking at specific years, for example. Again, this slide will mention some of the limitations that I just went over. If you do want more detailed information, again, please refer to the appendix of the report itself. Okay. And so now I will be passing it over to Sarah to take us through the highlights of this section.
Thank you, Dr. Talangi, and good morning, everyone. The graphs I'll be presenting are highlights from the Substance Use and Rural Communities chapter. For more detailed information, please refer to the statistical report. These first three maps indicate 2016 to 2018 annual averages of past year substance use disorder by county. These visuals only display substance use disorder among individuals aged 18 and older from the National Survey on Drug Use and Health. The color of the maps are different based on substance and are consistent throughout the statistical report. For example, all graphs presenting data on illicit drugs are in red. The map on the left displays substance use disorder percentages ranging from 6.72% in Kauai County to 7.47% in Maui County. The middle map displays percentages of illicit drug use disorder. Kauai County had the lowest percentage of 2.32, while Hawaii County had the highest percentage of 2.62. The last map on the right displays alcohol use disorder. Unlike the previous two maps, Kauai County had the highest percentage of alcohol use disorder of 5.87, while Hawaii County had the lowest percentage of 5.44. Next slide, please. These next three maps are data from the 2017 Hawaii Behavioral Risk Factor Surveillance System. The left map shows percentages for alcohol consumption in the past 30 days. As you can see, Kauai County had the highest percentage of 30-day drinking with 55.2%, followed by Maui County with 53.4%. Similarly, Kauai County had the highest percentage of 30-day binge drinking, which is shown in the middle map. Honolulu and Hawaii County both had the lowest percentage of 30-day binge drinking with 19%. Finally, the map on the right shows prescription drug overuse. Hawaii County had the highest percentage of 6.9, while Honolulu County had the lowest percentage of 3.9. Next slide, please. This third visual displays percentages of public high school students who have ever used cocaine, ecstasy, or methamphetamine in 2017 from the Hawaii Youth Risk Behavior Survey. As you can see on the map on the left, Maui County had the highest percentage of public high school students who have ever used cocaine with 8.7%, followed by Kauai County with 8.5%. In the middle map, we can see that Hawaii County had the highest percentage of public high school students who have ever used ecstasy with 7.2%, while Honolulu County had the lowest with 5.6%. The map on the right indicates that Maui County had the highest percentage of public high school students who have ever used methamphetamine with 6.2%, while Honolulu County had the lowest percentage of 4.3%. Next slide, please. This final graph is from the treatment section of the Rural Communities chapter. It presents estimates on needing but not receiving treatment for substance use in the past year at a specialty facility from the 2016 to 2018 National Survey on Drug Use and Health. Specialty facilities include inpatient stays at a hospital, rehabilitation facilities for both inpatient and outpatient services, and mental health centers. The treatment data on the 3 maps only include individuals aged 18 and older. The map on the left displays estimates for needing but not receiving treatment for substance use, which includes both illicit drugs or alcohol use. And Maui County had the highest percentage of 7.27, while Kauai County had the lowest percentage of 6.67. The middle map displays needing but not receiving treatment for illicit drug use, ranging from 2.03% in Honolulu County to 2.43% in Hawaii County. The last map on the right shows needing but not receiving treatment for alcohol use. Hawaii County had the highest percentage with 5.74%, followed by Maui County with 5.59%. Now I will pass it back to Dr. Talani for the discussion portion of this chapter presentation. Thank you.
Thank you so much, Sarah. So again, we are at a discussion portion of the presentation. We have roughly about 10 minutes. Again, we encourage everyone to post your questions and your comments to the discussion questions as well. So the first question is, as subject matter experts, what are some key highlights on substance use among rural communities that you would like to share with the audience? So again, this is going to, I'm going to pass it over to our subject matter expert and chapter lead, Dr. Witty, to answer first, and then we'll have the rest of our panel weigh in as well.
Thank you so much, Dev. So I don't think it's any surprise to anybody that the rural communities in Hawaii all said that they don't have enough resources. They all need more providers. They all need more services. That's been standard for a number of years and something we really need to work on. But other things that came up are that there are some services that can't be accessed because lack of communication and collaboration between organizations. So that was something that was emphasized by this group that can really be tackled, I think, in the near future. They also mentioned that, and as you've heard on this call, research in small populations is not adequate. The numbers are so small in some of these areas that they're just not reported. And so the rural areas wanted more research done specifically on rural areas. So other things that you have heard from Lily Noe and others are that they need culturally appropriate treatment methodologies that are not available in rural areas. And so that was something that was pertinent to all the rural areas and should be addressed. Other things that Lily Noe mentioned that rural areas concur with are the need for peer services and recovery communities. And so while there are some resources in all these rural communities, they do not meet the needs. And there are many things that can be done. And actually one that I didn't really think about, but of course people on the Big Island do, is transportation. So you may have a provider in your area, but not be able to get there, or you may not be able to get your medication sent to you because you don't have an address in a very rural area. So there was a lot of factors that we expected to find, but some new factors that are reported in this chapter. And I'll turn it back to you, Deb, or anybody who wants to address that.
Thank you, Kelly. I'll pass it over to John. He has his camera on.
I totally agree, and with those findings. So thank you so much, Kelly, for chiming in, and particularly, listing all of the folks, the entities that are out there that are doing something with respect to addressing substance use. That was very helpful. That's something that we need to, ADAD needs to constantly be have a pulse on in order to better coordinate and collaborate, which is one of those big gaps that you mentioned. And So we definitely, can do better. There's lots of room for improvement especially in the rural areas. And by rural, we're talking generally, I believe we're talking about areas that are outside the island of Oahu. Generally speaking, there are different points of view, but that's how we've typically approached it. But not to say that there are other rural parts of Oahu that have those disparities. And so if anyone in the audience, and this is where I want to ask for your feedback, is if you know of any other sorts of entities that are out there, maybe privately funded, or maybe they don't have any state funding, but they're doing something good, doing something well, or they just started up. We would love to know about who those players are, so that we can connect, because I think we could definitely do a better job at collaboration, especially in the rural areas. And also, we respect the fact that no two neighborhoods are alike, and there may be communities out there that may be more hard pressed in terms of substance use issues or co-occurring issues than similar communities right next to them. So.
And there's some good chat here too. Colleen mentions that Kauai needs transportation as well. That's a big issue. And then lack of broadband, Sally mentions, is a big issue because now we're doing a lot of telehealth, but if you can't connect to the internet, you can't do telehealth.
Mm-hmm. Yeah, that's right. And so we have some, the funding block grant supplemental funds that would I believe was intended to address some of those, especially on the tech side, and and maybe Jared would have some thoughts on it. But whenever you look at these federal data sets, they keep talking about prevalence, and I know Dev and his team has been looking at the tens of thousands of folks that need treatment but aren't getting it. And so I think a big question that this plan needs to resolve and address is, how do we reach that 80 to 90% that need services but aren't getting it, both on the prevention side, the recovery, and the treatment side. And so we welcome your comments on this. And thank you so much, Kathy. I see your comment in the chat. Thank you so much, Kylie. This is very valuable feedback. And we've heard about ECHO, Carrie. I'm not so well versed in it to talk about it right now, but there's.
I actually am very well versed in Project ECHO, and I can tell you that we have at least 4 Project ECHOs in Hawaii that are on a regular basis. One is behavioral health every Tuesday at noon. One is geriatrics every other Wednesday at noon. One is pediatrics, the alternating Wednesdays at noon. And one is medication for opioid use disorder every Monday, once a month. And you can find more out about that at hawaiiecho.org. But do we need more ECHOs? Because those are case-based training for providers. Maybe we can find a way to make those ECHOs more well-known. Yes. Yes, we can send this information out.
Definitely. We can always, and particularly for our substance use counselors or special prevention specialists, we could make CEUs. Well, talk to our QA office to make CEUs available for those. Definitely, we are looking for other trainings and other training speakers. Build up our speakers bureau. And yes, Carmen, more ECHOs for harm reduction. Definitely. Thank you so much, Laura. Yes, that's what we need to hear. Alignment with the Medicaid division. Just 2 floors up from me.
So we have the monthly medication for opioid use disorder, ECHO, but more harm reduction. I'd be interested to know more about what you wanted, Carmen. Let me know. And actually the comment on MedQuest, well, just in general, the collaboration between different groups would be really helpful, because sometimes someone is emotionally ready for rehab, but if they've already gotten clean, they're not accepted to rehab. So there's just an example of creating a way for someone to have a smooth entry between detox and rehab, and have it covered by insurance. So that's just one example of where our coordination lacks. So there's a lot of those examples. And let's see, we need more funding for prevention programs. Oh, this is so true all over the state. And this is where the comments on community specificity, you know, the knowledge in the community would drive the prevention efforts. That would be really helpful, because every community is different, as was mentioned. And so every community probably needs a different prevention program. So how do we help that?
Yes, exactly. And, you know, we wish to encourage more innovative programs, not so much those evidence-based programs that were made in the mainland, superimposed on local communities. Those may not, you know, we're interested in other sorts of practices out there as well. And we agree that we cannot, treatment services alone are not enough. Recovery homes alone are not enough. We need prevention. And particularly not with the vaping rates, but then also with the potential, if the legislature is going to potentially legalize cannabis and non-medical use of cannabis in future legislative sessions, you know, that's something to watch out for as well.
And
Thank you.
I'm going to contact
Sorry,
Laura
sorry.
and ask her to present at Behavioral Health Echo about how we get people into treatment, because that's super helpful.
Thank you so much to our panelists for the discussion, and also all of you participating in our chat. This is great. I wish we could have more time to go over some of this. But I will pass it on to the panelists to have some final thoughts quickly before we wrap up our presentation for today. Any of our panelists?
And Kylie, I'm going to give you put my email address in the chat. So please tell me what sorts of programs you're involved with. Maybe you know some other players. And question on whether we can save the chat. Dev, team, great idea.
One thing I didn't mention is stigma, and it is huge wherever we are. And so that's something that really needs to be looked at and addressed on many levels.
Definitely.
Okay, so we are now at 12 o'clock on the dot. Thank you so much for to our panelists. Again, I wish that we had more time. We will definitely save the chat and we can send it out, all of the links as well. I think that's something that would be really helpful given the discussions. And I think as we wrap up, we would just like to remind you that we have two more webinars, one next week on Friday and another on the week after. Our contact information is on these slides. We will send these out, and if you would like to contact John at ADAT or any of our chapter leads or subject matter experts, please do that. And we have the links to all of the documents that we put in the chat window earlier. Finally, again, I just wanted to remind everyone that we do have a post-webinar survey. Please take a couple of minutes. It'll only take a few minutes. We would really appreciate that. And again, thank you so much to our panelists, presenters, and especially to your audience. Mahalo, and hopefully we will see you at our next webinar. Aloha.
Hello, and thank you, everyone. Have a great weekend.